Hello everyone, my name is S.Osmani and I'm a third-year medical student who will be presenting this case that I worked on with Dr. Hilary Elwood and Dr. Nayara Barbosa, titled Primary Cutaneous Mucinous Carcinoma, a rare tumor of sweat gland origin. First, a background of mucinous carcinoma. Mucinous carcinoma is a malignant tumor characterized by abnormal mucus secretion, and it most commonly presents as a subtype of colorectal, breast, and ovarian cancer. Its prognosis depends on the tumor stage at diagnosis and the site of origin. Specifically, deep visceral organs have worse outcomes than superficial sites. Mucinous carcinoma can also present on the skin. This more commonly occurs as metastases from mucinous carcinoma of internal origin, but it can also be a primary tumor, which is called primary cutaneous mucinous carcinoma, or PCMC. PCMC is very rare, with a prevalence of as little as 0.1 per million people, and its histopathology is identical to mucinous carcinoma arising in internal organs. Therefore, a full clinical workup is needed to make the distinction between the two. Our case description. A 58-year-old female presented to the clinic for evaluation of a growing lesion on her left cheek. The lesion had been present for months and was overall asymptomatic. On physician exam, she had a subtle 1 centimeter pink papule with an underlying 2 centimeter subcutaneous nodule in the left periorbital area. The review of systems was unremarkable. A biopsy was obtained that showed fragments of glands floating in mucin that stained positive for GATA3, mammoglobin, cytokeratin 7, which is seen in the bottom image in the middle column, and cytokeratin 20, and negative for napsin, thyroid transcription factor 1, caudal type homebox 2, calponin P63, smooth muscle actin, and paired box gene 8. A diagnosis of mucinous carcinoma was made, but further workup was necessary to determine whether the tumor had originated on the skin or metastasized from a distant site. A full-body PET CT scan, a colonoscopy, and a mammogram were all unremarkable, so the diagnosis of PCMC was made and the patient was recommended for further surgical removal with Mohs micrographic surgery. The origin of PCMC is skin eccrine glands, and the typical presentation is a small nodule that suddenly enlarges. It is most commonly found in the periorbital area and scalp of patients 50 to 70 years of age. Before the diagnosis of PCMC is made, it is important to rule out metastasis of mucinous carcinoma from internal origin. Therefore, additional workup, including full-body imaging and colonoscopy, is recommended. Differentiating cutaneous metastases from a primary tumor can be challenging, and histological stains might be helpful, but ultimately it's the clinical workup and the history that make this distinction. Standard treatment for PCMC is surgical excision with at least 1 centimeter margins. Generally, this results in good prognostic outcomes. Although the recurrence rate is relatively high, with some estimates of as high as around 33%, more recent case reports have shown Mohs surgery may demonstrate better outcomes and cure rates. In conclusion, it is important to remember that mucinous carcinoma can present on the skin, both as a primary skin tumor, like PCMC, or as metastases from more internal sites, like the GI tract and the breast, and that a full clinical investigation to determine the tumor's origin is necessary, because making this distinction improves patient treatment and outcomes. Thank you very much for your time and your attention.